Good evening, everybody. This is Dr. Gary Gerber. Welcome to our webinar tonight with myself and Dr. Kevin Chan. Topic, as you can see, is a introduction to myopia management, our experience at Treehouse Eyes working together with OCULUS. It's a very timely topic. Sometimes it's kind of bittersweet when there's a pandemic going on to talk about things that are clinical, but one of the things that's been popping up a lot in the popular press is that obviously with kids being home so much and spending so much screen time, that parents are not necessarily connecting dots between being inside and mirror work with myopia, but they know that it's probably not a good thing to have their kid on the computer all day long. And there has been some popular press comments coming up related to myopia. We think you're going to see more of them. So the timing of this right now of learning about myopia management and getting ready to bring it into your practice is really kind of fortuitous. Maybe that's one silver lining with all the craziness we're going through, because it is a really good time. If you're contemplating bringing myopia management into your practice, now's a great time to do it, because when you finally do go back to some sense of quasi-normal in your practice, there's going to be more awareness of myopia. I'm the co-founder of Treehouse Eyes. I'm also an owner, so by way of financial disclosure, I have a significant interest in Treehouse Eyes. We've been working together with Oculus almost since the start. They've been a great company to work with. We are, regarding Treehouse Eyes and some of the content that you're going to see from Dr. Chan, we've got 15 locations in the US, and we're expanding across the country. If you have any interest in learning about our expansion model, once you get all excited about myopia management, you can contact us. It's grow@treehouseeyes.com, and we'll tell you all about how our model works. I'm going to introduce our panelist. Dr. Kevin Chan has been running one of our DC centers. He's the center director in Tysons Corner, Virginia since opening day. He's treated hundreds of cases, has really got a great understanding of how to use the Oculus technology, probably better than I could say anybody in the country with regard to myopia management, because he's fit so many cases and seen so many kids. He's got an interesting talk. He's going to kind of give it to you as an intro. He's got a couple of cool case studies. He even has a case study where we're actually showing a kid got less myopic as measured by the pentacam and axial length. So you're in for a really great talk. As far as questions go, you'll see a chat room button to the side. You can type in your questions, and if the question is on topic and there's a natural break, I will politely interrupt Dr. Chan to take the question. If not, we'll reserve all the questions for the end. So just as a question comes up, while it's on your mind, be a really good time just to type it into the chat window, and then we'll go from there. So Kevin, take it away.
Sure. Hi, everyone. Thank you, Dr. Gerber, for the kind introduction. And also, I appreciate your time joining us in this difficult and settling time. I know, just like many of you, we are working for seeing emergencies or medical eye care only. So our hour has been, somewhat different from what we used to be, but I hope that we are all going back to normalcy very soon. So today I would like to give you some introduction regarding what I do every day in terms of myopia management. Particularly, we have a really great collaboration with OCULUS, and I've been using some of the technology provided by OCULUS, with great success. So I just want to share some of the stories with you today. So to start off, I have no financial disclosure. And here I want to show you there are two different statements made by different organizations. The first one is the International Diabetes Federation. And their statement says, according to the current trend, it projects every 1 in 10 adults would have diabetes by the year 2040. So essentially 1 in 3 will have diabetic retinopathy, all right, by then. If you try to mirror a myopia with diabetes, it's actually quite similar. If you look at the trend, according to the myopiainstitute.org, they said the current trend project every 1 in 2 people worldwide will essentially have myopia by the year 2050. So essentially, by that time, almost 5 billion people worldwide would have myopia. So what does myopia bring to the table is that there's always some clinical relevance to myopia, is that when we have, high myopia to the point where patients have a lot of retinal changes, myopic maculopathy will be one of the leading causes of blindness worldwide. So for the sake of time here, essentially this is a slide that I have, used for other seminars for providing attendees about the basis of myopia. So I want to briefly introduce you what myopia is and why it matters so much to our daily practice. So myopia essentially is manifest as a result of physiologic disturbance to equilibrium in the ocular development. So when you look at our typical ocular development, we're looking at the process of amortization. So when something is missing or being interrupted during this amortization process, it would definitely causing some disturbance to our healthy eye. And myopia is one of the results. And because of myopia, its deterioration will become a global dilemma that actually warrant proactive intervention among all of us as a healthcare provider. And last but not least is that when you do myopia management right in a proper way, it can really make a huge difference for kids' life. So patient as young as 4 or 5 years old can be sitting in your chair and complaining about blurry vision when they see on the board in the classroom. And most of the time, we may not take it too seriously or simply provide them the conventional way of correcting myopia. So correcting myopia is actually different from managing myopia. Hopefully, by the end of the exam presentation, I will be able to give you some of the insight about the distinction between these two. So in terms of technology, in Treehouse side, we incorporate one of the coolest thing ever on earth. It's called the OCULUS Pentacam AXL. And essentially, it's a non-contact anterior segment tomography with a 3-dimensional shine fluid imaging. And later on, I'll explain to you some of the nuances about these imaging technique. So this particular cool machine allows us to take precise measurement and diagnostic data for the entire anterior segment, ranging from the cornea all the way to the crystalline lens and to the back of the eye, in one single measurement. And in particular, this type of Pentacam can actually integrate axial length features in order to aid the accurate IOL calculation as well as myopia management. So for most of the ophthalmologists or your colleagues working with the refractive surgery, I think Pentacam is actually pretty commonplace for most practices. But in optometry, it's still relatively new. So I want to spend some time talking about this. So we have briefly mentioned the term called shine fluid imaging. Now, essentially, shine fluid imaging is a really sophisticated technique. I'm so-called not an engineer, so I will just touch upon some of the stuff, the basic stuff that I know I can share with you. So essentially, this type of imaging technique is to make use of the rotating camera in order to capture the corneal cross-sectional slice that is illuminated by slit beam at different angles. And because of this type of cool technique at different angles, they're able to capture the image with the extended depth of focus without the change of the aperture. As we all know, using pinhole effect, we can actually narrow down the aperture in order to increase the depth of focus. But for this type of imaging technique, we don't have to sacrifice that aperture changes. And when you look at the specific data point, this type of shine fluid image is very powerful. It can actually acquire almost 25,000 data points in just 2 seconds. And depends on the model and how the setting set looks like. For our clinic, we typically start off with the 25 cross-sectional image per slide. So, but it actually can be powerful up to taking 50 cross-sectional image from 0 degree down to 180 degrees in just one single scan. So again, it's a really powerful, cool technique. Even many patients are really amazed by how quickly it can capture the most detailed image ever. So here's the example showing you what this shine fluid imaging is taking. So like what I said, in our clinic, we typically, for the sake of time, we typically don't want to spend time to take almost 50 image per slide. So because we're dealing with the population being pediatric, the short attention span and the fixation is not very cool as much as an adult. So we try our best to get the most out of the imaging technique by using the shorter amount of time. So for that reason, we tend to set the number of imaging taken up to 30. So here's the general overview once we take the picture from the shine fluid imaging camera. So what we're seeing is that there are a couple of things we want to touch upon here. The first one is the one shown on the right-hand side. As you can see, there's some K reading, keratometry, and the one below indicate the pupil size. Later on, I'll touch upon why pupil size may matter for our clinical studies. And also followed by the HVID. When you talk about especially myopia management fitting with ortho-K lenses, HVID is really critical in terms of how we can optimize the lens design and also give them the best treatment outcome. The legend shown on the left is the one called the dosimetry. All right, that is actually the fancy word showing you how the cornea looks like and the corneal clarity. So essentially what it does is to indicate what kind of cornea we're seeing here. If the value is less than 30, it generally means it's normal. For this case, this particular image is slightly over 30, around 35. So it's still considered acceptable for having a good corneal clarity. But on the other hand, you can actually use this pentacam to kind of screen through a patient with, especially for adult patient, if they have some sort of endothelial cell count problem or having fuchs dystrophy. Those are the features that you can make use of. And last but not least, later on we'll touch upon in extensive detail about axial length. And this is one of the coolest things, OCULUS can provide for our patient for myopia management. So once I take the picture and look at the overview, I generally will go through the specific image in detail. So here I'm showing you the selectable map, showing you, let's go from the image on the top left-hand corner. So that is the axial or sagittal map. Okay, that's what it tells you what the cornea looks like in terms of the corneal power. So think of this as like looking at the power from this inside out. If you have someone who have a really steep cornea, you can actually see the image is really warm. Moving on to the top right-hand corner, you have a tangential map. Essentially, is the overall comparison among the corneal curvature. So I personally like to look at the tangential map when I look at the data from a day one standpoint up to 6 month standpoint and so forth. It's really critical to see how the curvature looks like, especially for someone who are undergoing treatment with ortho-K lenses. You want to see how the treatment is working with the ortho-K lenses. Otherwise, you have no way to know what the actual acuity looks like or whether patient have any other particular symptoms associated with that. And moving on to the bottom right corner, you have an elevation map. Essentially, it's going to tell you indirectly telling you what the corneal toricity may impact the overall ortho-K or just contact lens fitting in general. And last but not least, you can also use this type of imaging technique to capture pachymetry. For practice who do a lot of like LASIK consult and stuff like that, pachymetry is definitely one of the critical component here. And essentially, we want to know whether or not patients have any signs of corneal abnormality, such as keratoconus or pellucid marginal degeneration. All these kind of abnormality need to be ruled out before we consider getting kid to be treated for myopia management. So here comes to the topic of axial length and the ocular growth. So essentially, this is in my opinion, is a really important slide. This is how we start with, how to understand myopia in general. Because myopia has to be understood in a different way, I will kindly challenge you how you view myopia when you go back to the office. Essentially, we talk about myopia in many ways, but most of the time we just understand myopia in terms of the refractive error. But more and more studies have found that myopia is actually more than just the refractive error changes, but it's actually more to do with the structural variation of the globe. Essentially, myopia occurs when there's a mismatch between dioptric power and the physiological length. So essentially, obviously, the dioptric power is increasing while myopia is getting worse. So is the axial length changes. And one of the most critical factors associated with myopia development and the axial length elongation is the age. Typically, we see a lot of patients at young age with relatively faster growth of axial length. There's actually a study done in 2018 by Kushek and Logan. They actually found that there's a lower threshold for axial elongation for each diopter or refractive progression. So particularly if they're looking at two different parameters using the age and also the level of myopia as the parameters. What they found was the lower the myopia, the lower the threshold of axial length changes. So indirectly speaking, we're talking about if patient have one diopter change at 6 or 7 year old, essentially the axial length changes typically correspond to about 0.3 to 0.4 millimeter. On the other hand, if you have an older kid at 13 or 14 years old, but with a higher perception of myopia, for every diopter changes, it generally corresponds to a higher level of axial length changes, closer to 0.5 to 0.6, according to this paper. And as we can see anecdotally, there's a strong but not necessarily linear relationship between the level of myopia and ocular growth. What I mean by that is that there's oftentimes that you have a low myope, as little as -1 diopter coming into the office, and basically they may not have symptoms about blurry vision, at least not they're aware of. But when I look at those patients, I also have to be cautious about what the axial length looks like at baseline, because oftentimes you'll be surprised how long their eyes are, even at -1 diopter. So sometimes the relationship, even though they're all most likely positively related to each other, but they're always not linear to each other. So meaning sometimes patient can have a really low myopia, but the axial length changes is actually closer to 26 to 27 millimeter in size, which is almost like an adult eye. So here I found a cool image from a histological slide here. All right, the one shown on the right indicates the normal ametropic eye, and the one shown on the left is the one with myopia. So essentially, without explanation, you know that the eye is elongating. But what is the complication or sequelae of axial elongation? Number of studies have found that axial elongation is not just about the eyeball being bigger. All right. Yes, you can kind of explain to patient that this is the way it is. When your eye get worse, getting blurrier. But clinically speaking, we all have to understand what the implication would be, including RPE disruption, also scleral thinning and extracellular matrix remodeling. And as a result, the sclera can also impose some sort of posterior ectasia. So all these things may involve in terms of axial length elongation. So keep this in mind and feel free to capture this image and show it to your patient what it actually means when you talk about axial elongation. So let's go back to our clinical bedside here. Okay, we have a patient, coming in, and I did a baseline measurement. Axial length shows that he is at around 24.7 millimeter. And we typically take a couple measurement on average of 6, so that will actually increase the reliability and the accuracy here. So I want to highlight about when you look at axial link measurement, not every axial link data is actually reliable. You have to look at also the noise signal to noise ratio, the SNR. In this case, patients have a really good signal to noise ratio over 200. And what it means is that patient really have a good fixation, also have a really proper posture, and that's why they have a really good data involved. As you can see, the graph shown below at the circle in the red circle there. And what we're seeing here is that patients have a really sharp peak with low interference in the neighborhood. So it tells you that this data is reliable. Otherwise, even though you may have a good data, but if you can see the graph to be very like a seismic activity to the level where you cannot really analyze which one is the peak, then you have to redo this picture again. So let's talk about many patients, or actually many clinicians have asked me about what can I do to start with myopia management. Once they understand why axial link matters, the next question they will ask me is, okay, what kind of instrument or biometry we should consider for axial link? And I will just give you my personal information here. There are many other optical biometry. You can Google it, including a big major IOL Master, Landstar, or Aladdin. So here I'm going to show you what the basic preliminary biometry you can use. A scan using ultrasound, all right, essentially is using a frequency of 10 megahertz to do the job here. And the advantage of using A scan is they're obviously very lightweighted and they're portable. If you have multiple offices, you can definitely transfer this A scan from offices to offices. And to start off with myopia management, you want to keep the cost relatively low. So A scan will be a good starting point, but there's always some expenses here, all right? Using A scan requires topical anesthesia. So for someone, especially when you're dealing with young kid, having a probe, directly onto your eye and applanate it gently, all right, is not a fun thing for them, and also not a fun thing for you. So you really require a lot of patience and coordination in order to make it work reliably. And obviously, we talk about fixation, and patient's apprehension could be one of the key factors that would affect the overall liability of the data. And because you're probing the eye so many different times and you don't know where exactly you're probing at, even though you assume you're probing at the visual axis, but not oftentimes you hit the right spot there. So in comparison, what we're using in our office in Treehouse size is that we're using the Pentacam AXL by Scheimpflug imaging technique. What it stands out was that I'm really amazed by how reproducible and accurate it is. Usually we're talking about the axial link measurement down to 1/1000 millimeter. And because we don't use probe, there's no worry about direct contact with the cornea or having any fidgety behavior from the patient. And this type of instrument is also tear film independent. So especially for someone who have dry eye or any other particular ocular surface issue, you definitely you don't have to worry about this issue, because you don't have to worry about tear film in general. It doesn't really affect the overall result. And if I can tell you that I can use this Pentacam AXL on a 6-year-old kid with fidgety behavior, all you have to do is to let them stay still for 5 seconds, all right? And it's pretty user-friendly. And obviously, all these pros come with the costs, but think about this cost could be a long-term investment for the best interest for your patient, and you can also build up your specialty niche in your practice. And the downside I personally can think of is, because it's a really big machine compared to a scan, sometimes it could be difficult for office to transfer from one place to the other. You really have to have a separate compartment in order to make it work for your office. So here's my daily life, all right, and I'm actually using Pentacam on the right-hand side with a 6-year-old kid. He's actually one of my best patient ever, and even though he's only 6 years old, he can actually do much better than an 18-year-old guy. So I'm actually quite impressed by how user-friendly it is, and even a 6-year-old can handle this. So here I want to show you and touch upon why capturing the technique of capturing is important here, because I'm showing you there are two different snapshots here. The one shown on the top is the ideal capture from the shine fluid imaging. So what I did was patient used to have a really narrow pupil fissure, and the lid architecture essentially doesn't allow the natural apposition to be wide open. So as a result, I really have to open his eyes in order to capture the full HVID. And as you can see, this is the cross-sectional view showing you from the top lid all the way to the bottom lid. And you can see the entire cornea and appreciate all the anterior segment component here. Whereas at the one shown on the bottom, you can see that patient does not really want to open the eye fully open. So as a result, you will expect a limited capture from the Pentacam. And not that it will not be working, but it's just not giving you the feasible or usable data. And essentially, as you can see on the cross-sectional view, or here we are seeing maybe just 2/3 of the entire cornea. Half of the lid obscure the image. So as a result, what we are seeing here is that patient can either be fidgety or the fixation can also compromise the overall results. So by comparison, I strongly recommend clinician to consider if you have a patient having narrow lid aperture or simply they cannot really open the eye automatically, you have to open the eyelid manually in order to capture the reliable data here. So let's start with the first case study here. So I have a 10-year-old African-American male referred by his primary care optometrist for the initial consultation for myopia management. His current old glasses give him a relatively good vision, but mom was concerned about 20/25 vision and 20/40 vision. And when I look at the clinical record from the primary OD, it shows that his current prescription had worsened by about half a diopter on the right eye and 3/4 diopter on the left eye since a year ago. And once I cycled the patient, I found that his current prescription after cycloplegia refraction was about -4.25 diopter on the right, and then 475 on the left. And one thing to mention is because patient, especially when they're doing myopia management, most of the patients are having active or athletic lifestyle. For this patient are really active in Taekwondo, and obviously glasses is out of the equation. You don't want to jeopardize breaking glass every single week. So let's take a look at the whole data set and think about what we can do for this patient. When I first start up, I look at his map here. As I showed you earlier, we're interested in knowing what different map shows me in order to give me the best decision making here. So here we're seeing the axial curvature and the elevation map and also the corneal thickness. Everything looks pretty ordinary and there's no signs of keratoconus or any other corneal abnormality. So the next step for us to consider is what can we do for this treatment and how do we treat this patient? Now, when you go back to the data, all right, patient was precision-wise is less than -5 diopter, and his K reading is around 42 to 43. And that makes the patient to be a pretty good candidate for having orthokeratology lenses. But don't forget, we have to look at other data, including HVID. Typically, we want to have a patient with a relatively ample HVID, closer to 11 millimeter in size. And as we mentioned about lifestyle and motivation, all these things come into play when it comes to what type of treatment we are going to fit for the patient. For this particular patient, because we talk about he's very athletic with Taekwondo and any other sort of athletic lifestyle, and patient seems to be relatively compliant with instruction and all the conversation. So as a result, we actually prescribe the patient with the customized ortho-K lenses. In Treehouse side, we have the patent pending proprietary lens called the KISS lens, known as the keratometric induced steepening, dioptric steepening. And later on, I'll talk about what it means by that, because for ortho-K lens to work for myopia management, it has to be customized in order to have the relatively ample peripheral steepening effect. And that's why we want to start off with the intention with the outside component first. So I've seen the patient and followed with him for about 6 months or so. And patient seems to be relatively receptive to the ortho-K lenses, and the data have shown that patient have remarkable findings upon 6 months or so. Patient is seeing 20/20 native visual acuity. And as you can see, the one shown on the top left-hand corner, we're seeing the 6 months post-treatment topography map. Here we are seeing the essential central flattening surrounded by the full circumferential mid-peripheral steepening. That is the typical classic signs of ortho-K lenses. And if for some reason you have seen other data that is different from what we're seeing here, then you have to know how to troubleshoot it. And in fact, I have done a different lecture talking about how to trouble specific or ortho-K lens here. Here's the second case for a 16-year-old, his Indian female. Her first consultation was done back in 2 years ago. Her first refraction was shown to be about -250 since grade 1, first grade. And according to mom, her vision seems to be getting worse by about half a diopter through 3/4 diopter every year. When you look at the family history, father is described as a fairly myopic, but mom is ametropic. And patients spend almost full time on the screen, especially during this shelter-in-place moment. Definitely, you have a lot of kids coming in, complaining about blurry vision, eye strain, all this kind of stuff. All right, and definitely screen time could play one of the biggest role in myopia progression here. Even though I'm not claiming that it's causation, but it's definitely there's an association between the number of hours you spend on the screen versus the rate of myopia progression here. And one thing I heard from the patient herself is that she really wants to be able to see without glasses one day. As you can imagine, she's 16, but she started wearing glasses when she was 5 or 6 years old. So in the past decade or so, she have no other choices but just to wear glasses. So I can see where she comes from here. So when you look at the clinical data in more detail, here we have the habitual glasses starting off with a really high myopia, -8 and -8.25 on the right and -8 on the left. Both eye have a relatively high amount of refractive astigmatism. And at that time, the primary care OD had prescribed her with the bifocal glasses. The distance acuity was about 20/30 in each eye. After I examined and evaluated the patient with cycloplegic refraction, I'm seeing some kind of hyperopic shift from the habitual data. In most cases, it's not uncommon because patients tend to over-accommodate, and it's always good to have cycloplegic refraction in order to get you the most objective data here. So after cyclo, I have gotten the patient down to 20/25 in each eye. The K reading is about 44 to 46 diopter, and both anterior and posterior segment are shown to be pretty clear, healthy, and remarkable. But given this high myopic status, it is not surprising to see that patients have white without pressure in both eyes, but there's no signs of any other retinal abnormality here. So here is the baseline biometric data shown on this patient. Again, I will just highlight a couple of things that you want to pay attention to before you start off with thinking about what to do with this patient. Obviously, we have to look at the K reading, HBID, axial length, as well as the overall pachymetry here. So I want to briefly touch upon what we do specifically with, patient with corneal irregularity. The first thing is to look at the sagittal height differential. I use this a lot in daily practice just because by just looking at the previous map, I still don't understand or may not fully cannot appreciate the whole, how the corneal map looks like, in terms of where it's steepened or where it flattened. So sagittal height differential helped me a lot. When you look at this sagittal height analysis by the Pentacam AXL, it really tells you where the cornea is sitting here. All right, this little box right here tells you the actual meridian and the actual micron, where it shows to be steepened and where it shows to be flattened. All right, by using this little box, I can calculate the actual amount of differential between the horizontal and vertical meridian in order to know and understand what the next step would be. For instance, if I have a patient having the differential greater than 30 micron in absolute value, I would definitely start with a patient with a toric design, especially for someone with ortho K lens treatment. And for someone who have less than 30 micron differential, I would typically be more conservative and start out with the spherical lens design. But in some exceptional cases where a patient do have a low differential less than 30 microns, but we're seeing some sort of asymmetric corneal toricity, I would definitely consider talking to the lab, and the consultant will actually walk you through the step. Especially in my clinical experience, I can tell you asymmetric corneal toricity would definitely warrant some sort of toric design. Even though it's anecdotal, it's off-label, but it's definitely something it's worth considering. So let's look at the data after fitting the patient with the ortho K lens design. Here we have the 1 week, starting with the 20/30 vision on the right, 20/50 on the left, being tested in the morning. 6 weeks later, patient have improved significantly down to 20/20 in each eye. Again, we tested in the morning. Fast forward 6 months later, we're still seeing patients have a really strong and consistent visual acuity down to 20/20. But this time, we have the patient come back in the afternoon so that we can capture the image between morning and afternoon and look at the overall comparison. Sometimes patients would complain about vision being the strongest or the clearest in the morning, but sooner or later, vision can get wind down towards the end of the day. So you want to know and evaluate how good the vision can be and how long it can last. And even when I over-refract the patient at that time in the afternoon, patient remained solid 20/20 in each eye. So let's look at the data from a different aspect here. All right, we're looking at the comparison between pre-treatment shown in the middle and the 6 months follow-up treatment on the left-hand side. So what you can see here is by using Pentacam AXL, we're able to capture the image in one single snapshot. And in fact, this patient, as Dr. Gerber have alluded earlier, we have cases, actually not just a few, but many cases where a patient, when they start out the lenses or any type of treatment with either lenses or atropine treatment, their axial changes is actually quite surprising. For this particular case, patient shown on the right eye to have a regression, a slight regression by about 0.17 millimeter in just 6 months. Let's take a look on the left eye here. Here's the left eye. And again, we're seeing that pretty solid 6 months post-treatment results. And the axial changes is actually going backward, and there is some physiological regression by about 0.17 millimeter in size. So I'll quickly touch upon this case number 3. This is a 6-year-old Caucasian female, and she has a history of failed vision screening in school. And at that time, mom and dad doesn't realize she actually have any vision changes or any problem in school until they brought her to see the primary eye care provider a year ago. And at that time, patient was diagnosed with myopia the very first time. And so as a result, the primary care OD sent her for a myopia management with me. And at that time, the native entrance VA was about 20/70 in each eye. And after I evaluate and cyclopicture the patient, patients were actually shown to be about -1.25 in each eye with low refractive astigmatism, but it's correctable to 20/20. But one issue comes up when I talk to parents about prescribing any sort of optical correction. At that time, patient wasn't very receptive or compliant with wearing glasses in general. But because of this, patient was seeing 20/70. It's not acceptable, no matter whether you're in school or in the playground. So parents are concerned about what to do next. So at that time, upon extensive discussion and consideration with patient's age and her the reception about glasses in general, I think at that time we come across this idea. It's by using the atropine 0.02% combined with the soft multifocal contact lens as the adjunct treatment for this particular patient, because patient is a young age at a really rapid state of myopia progression. And at that time, if we don't do anything more aggressive, if you just prescribe glasses for them, they would definitely be prone to further progression over time. And like what I have said earlier, when patient at younger age, the actual axial link elongation will be more rapid compared to patient at older age with a higher prescription. So at that time, we started with the combined treatment regimen for this patient. And I want to touch upon some interesting and cool features from this Pentacam AXL. This is the capture showing the iris mapping, showing you I'm just taking the left eye example here. So the one shown on the left is the baseline on the left eye. The one shown on the right is the treatment effect after 8 weeks with the atropine here. So what I wanted to point out here is that pupil size sometimes can tell you whether or not patient is receptive to the treatment itself. Even though we know that atropine itself, even at relatively higher concentration at 0.05%, the actual pupil changes is very minimal, less than 1 millimeter in size for most cases. But this is one of the exceptions where patient is Caucasian and she's blonde, and she have really blue iris color. So for that case, we really have to pay close attention to how the pupil respond to the initial treatment. Otherwise, you have no way to know whether or not you should have any revision or titration with the atropine drops. So for this case, baseline shows to be about 2.3 millimeter post-atropine. After 8 weeks is about 3.6 millimeter. It's slightly bigger than what I expected, but fast forward patient after 3 months or so, the actual pupil size go back to about 2.5 millimeter in size. So here I want to show you a different perspective of how to analyze the axial measurement quantitatively. Here we're seeing the one shown on the top diagram. It is the axial measurement from baseline on the left eye. I just want to highlight the actual refractive changes at that time. Baseline was about 1.25. And upon year 1, something is changing. All right, this is something that is, while it's not uncommon, but it could be possible for someone who are considered having rapid progression here. So patient jumping from 1.25 to the 2.25 in just 1 year, even with the combined treatment regimen here. So what you want to see here is that patients have significant changes in terms of the axial length measurement here, from 23.1 millimeter jumping to 23.8. So you may wonder, it just off by about 0.1 decimal place. All right, is it really matter? Does it really important in terms of changing anything on the treatment? My answer is yes. It's because when you look at the microscopic scale, axial length tells you really, what to do proactively. If you wait until the refractive changes occur, probably it's too late. Just like use an example of, seeing an adult patient with dry AMD. If a patient, still have dry AMD, you don't want to take action, but observation only, then patient will sooner or later will become a wet AMD, which warrant further intervention. Obviously, you have to send them out for anti-VEGF and stuff like that. So my point here is that we don't want to wait until refractive error changes. That's why axial length measurement is paramount for giving you the insight, or so-called the intel, of what to do with this particular patient. So here what I'm showing you is the, just to recap, the year 1 measurement. And at that time, I have talked to the parent about, what this change is about and what the implication would be moving forward. So at that time, we decided to, go to change and revise the actual regimen here. And for the atropine regimen, we want to increase the dosing from QHS once a day before bedtime to BID twice a day. And there's some literature out there showing that increasing the dosing of atropine medication have some positive effect, even though it may not be a significant effect, but it actually is shown to be pretty significant in terms of how to regulate the overall axial length progression here. So upon 6 weeks since we make the revision for this patient from QHS to BID, patient actually is shown to have a relatively less axial length measurement here, from 23.85 down to 23.82. Again, we're talking about the nitty-gritty stuff here, but this is what matters the most when it comes to proactive management of myopia. So at that time, patient was pretty responsive to the treatment, and there's no potential effect of light sensitivity or any fluctuation in near vision. So we decided to keep this patient at this particular dosing at BID. And moving forward, I'm looking forward to seeing this patient in the next 3 months or so. So I have no other data that I can show you moving forward. But this is a really cool case. I want to share some of the insight with you. So whenever you go back to the office, at some point, I want you to bring something home and something to ponder when you go back to the office here. So having myopia management in your office is not just about a technique or some sort of service you want to consider. And in my personal opinion, it's going to involve some sort of big paradigm shift in terms of your mindset. Think of someone, again, having AMD. If you don't, consider having any proactive changes or measure for this particular patient, then you may expect to have extensive changes in the macula, and eventually patient may need to have the anti-VEGF injection. So what we want to do is to think of how we can change our mindset by offering them proactive step in order to prevent the progression from dry AMD to wet AMD. So one of the things that you all know is that you have to educate them with some protection and also taking antioxidant either by ARET2 supplement or other natural ingredient. Let's do this with a mirror with myopia. When you look at myopia, most of the time clinician may still think, may have a mindset holding in the mind that, this is just a refractive changes. Minus a quarter may not mean much to you, but eventually that minus a quarter will soon to become a -1 diopter. And again, the trend is going to be exponential, all right, non-linear. So you want to bring this topic to the patient, even though they may not be ready or receptive to myopia management in general, but you want to bring up the public awareness and talk about myopia in general, what we can do next year moving forward. And once we have that paradigm shift in our mindset, we want to take a proactive step and also plan it strategically. Otherwise, if you run over places and you don't really know where to start, that's another big pitfall for most clinicians. They have a really good mindset, but they don't really know what to do and how to start with myopia management. They simply hit all the spot without direction. So in that case, this is going to be very difficult for you and your practice. And last but not least, I want to highlight the importance of why we use Pentacam AXL, because it really helped me and surprised a lot of time, how accurate the data looks like. And it really helped me to capture accurate and reliable biometric measurement in order for me to make a decision making more sound for a patient. So at this moment, I want to open up the space and airtime for questions. And just to highlight some of the stuff that, this is our Treehouse size clinic in one of our offices, and we want to make it really kid friendly. I think Dr. Gerber can chime in here because he's part of the people to make the design working for this clinic.
Yeah, thanks, Kevin. Yeah, great presentation. I always learn something every time I hear you speak. So great, well done. Kevin, we do have a bunch of questions, so I'll start. Most of them are for you, one or two are for me. I'll give you the Dr. Chan questions first, the clinical stuff. Has anyone measured whether there is a change in the vertical length of the posterior chamber with increasing myopia?
The vertical length of anterior chamber for axial measurement.
Posterior chamber with increasing myopia. I've never seen it, but
I have read a few literature showing how the anterior chamber depth can be corresponding to the overall rate of progression of axial length changes, but I'm not quite sure what the posterior segment look, because in my knowledge I haven't seen any data about posterior segment yet. Yeah. But it's definitely one of the plausible component, because at the end, we're talking about axial length regards to the posterior chamber and segment.
Yeah, now we have to look at vertically versus horizontally if we even look there.
Yeah, yep. I'm not quite sure about this answer.
Okay. Let's see. Then another one is, hang on. Do you offer atropine with Ortho-K? If so, when would you recommend it?
Okay, it's a really good question. And just like the case study I've shown you, patient was using combined treatment with atropine and soft multifocal. For that question, with Ortho-K, I would typically start with considering what type of patient we're dealing with. If a patient at young age with very athletic lifestyle and patient doesn't have any incentive of wearing glasses in general, I would definitely offer them the option of getting Ortho-K lens to start with. If patient 6 months later and all the data suggests that patient have a rapid tendency to progress over time, I would talk about the atropine as the adjunct treatment for them.
Okay, thanks. You may hear the dog barking in the background. I can't help that, but I'll press on. You have noted a regression of axial length in some cases, as I have in my clinic. Is this just choroidal thickening in response to altered optics of myopia treatment as opposed to scleral shape changes?
Again, that's a really high-end good question, and I actually have read a few studies regarding choroidal thickening and also the scleral remodeling, and that could happen in combination of all the factors here. And I think the majority of the activity going on with axial regression, in my opinion, is about choroidal thickening. But there are other studies showing that if you have scleral remodeling, in fact, there have been a few groups, I think in Asia, they actually did some surgical intervention to thicken the sclera in order to prevent myopia. So that is a direction, moving forward, even though it's very preliminary. But I think it could be the direction moving on, regarding the choroidal changes and also the scleral changes.
Okay, next question's for me. What percentage of patients pay in full versus financing? What financing do you offer? I would say probably about a third of patients pay via financing. Of that third, probably a half of those use care credit, and then we also offer in-office financing ourselves. Oh, that was easy. Okay. Yeah,
Sorry, you got an easy question.
Yeah, I can't answer the hard ones. You got to see the patients, not me. How do you manage vision over the weeks of initial treatment? That one's for you.
Can you elaborate the question again?
Yeah, how do you manage vision over the weeks of initial treatment? I guess, like, for example, if the kid comes in, he's -4, and it's a 24-hour visit, he's -2, then he's -1. What do you do with his acuity in those interim steps?
Sure. Okay. So there are a couple of ways I typically handle this, by using some sort of adjustable glasses. Those adjustable glasses can actually help patient last for the first couple of weeks during the treatment. Like what you said, from a -4 diopter with ortho-K lens design, it may not be able to get them down to 20/20 right off the bat. So what I would do is either prescribing those adjustable glasses or some kind of single vision soft lenses to get them by. But most of the time, patient will be able to get over the hump after the first week or two.
Okay. At what point do you consider changing the strength of atropine versus changing the dosing?
So we're talking about the concentration versus dosing, right?
Yeah.
Yeah, so that is up in the air at this moment. There's currently no literature showing which one is better, all right? But most of the time, if we have an aggressive patient with aggressive progression here, we typically would start with revising the actual concentration rather than dosing. Think of it as like we want to hit the big target first.
Right. Okay. Let's see. Is the decrease in axial length after treatment due to flattening of the cornea?
That could be one of the byproduct, especially if you talk about patient with ortho-K treatment. Corneal
Yes.
flattening could play a role, but it's a relatively small role. Again, many literature suggests that it's about the choroidal thickening and how we can remodel the scleral thickening changes. And corneal flattening can be one of the confounding factor here.
Okay. What is the greatest SHD you have attained in your practice? I don't know what that stands for. Maybe.
XHD is the sagittal height differential. That's one of the slides talking about how to design the patient between, spherical versus toric lenses.
Got it.
So to answer this, I think on top of my head, I have dealt with someone with over 60 micron differential. That would put this patient to a really high category for fitting like a second or third tier level of toric lenses.
Cool. Got time for two more. With ortho-K, is night vision affected by steepening of the mid-peripheral cornea?
From what we understand about the principle of myopia, the mid-peripheral steepening is one of the biggest recipe for myopia management. But we still have a lot of stuff to know about what is the cause, what is the effect, and how much mid-peripheral steepening we have to induce. Those are the unknown that we still don't have answer about.
And then, but I can jump in a little bit because I've seen this in talking to parents and talking to kids. As far as the quality of vision at night, generally not a problem with kids. We think they're just a lot, their vision system's just a lot more kind of malleable and plastic, if you will, as compared to an adult who might have, if you're thinking of an adult who had LASIK with too small of a their ablation zone, they would complain like crazy. But kids, for some reason, don't. Kevin, I got one more for you, and then I'll take the last one. What is your impression of atropine rebound and how it relates to combo therapy?
Yeah, according to a lot of a few major study about atropine, especially the Atom 1, Atom 2, and the ongoing Atom 3 study, they found was that there's minimal rebound effect, even at a higher concentration of atropine at 0.05%. And chances are patient, especially at that young age, they have less chance of rebound. And sorry, what's the second part of the question?
Just how, let me see where that one go. How does it relate to combo therapy? I just guess atropine in general. They didn't really specify.
Yeah,
I guess.
so that's another thing that this is a future direction for us to understand myopia in detail. But for us anecdotally, we're seeing that patients do have a better treatment outcome with combined treatment here. At least I think at least 25% up to 30% of our patients are currently undergoing combined treatment because the initial solo treatment have not been seeing the result that we're expecting.
Okay, great. And I'll take the last one. It's one of my favorites. Can I give some information about our fee structure? Yeah, happy to. I can't give the actual numbers, but I can give you conceptually and tell you how we got there, which was based on consumer research. We have a fee model that's not widely used in myopia management. And the first thing from a high level is think of the Staples easy button. We want parents to make a decision whether they're going to get their kid treated or not, as opposed to should they treat the kid based on atropine, soft lenses, or ortho-K based on price. So we have one fee regardless of how we treat the kid and regardless of how many times we see that kid during the first year. So it's a fixed fee. And it's super easy to explain to the parents. The consumer testing that we did before we opened Treehouse Eyes, the concept of orthodontia came up. Orthodontists pretty much will say it's going to be $6,000 to straighten out your kid's teeth, and then they get into the details later, as opposed to saying it's going to be your kid needs 27 rubber bands to $31 each, and they need 14 inches of metal, and that's so many dollars per inch. So we adapted that model. They've been pretty successful with it. The other thing is we have one fee regardless of complexity of the case. I know some ortho-K guys in particular advocate charging more for more complex cases, for higher amounts of cylinder, or just more myopic kids. We don't do that, and we tweaked our fee algorithm such that, yep, every now and then Dr. Chan's going to get a kid who walks in who is -2 with a -350 cylinder, axis 31. And the mom insists on ortho-K, and it's going to take them a while. It's a tough one, but the next kid that walks in could be a -75 sphere with a 44 cornea. So based on the data and just kind of looking at it very carefully, we set the fee so that most of the time we're going to be just fine. And the lesson I would give for listeners is when you go down this path, just keep it easy for parents. Kevin, great presentation. Thanks so much. Awesome. Learned a lot.
Thank you, OCULUS, for having me for this webinar event. So make sure you register for the upcoming webinar. We're going to talk, even though it's not me, but we're going to talk about more about myopia management in a later week.
Yep, we got another one coming up Thursday. Make sure you're there. I'll be moderating that one also. We got some great speakers, some more great content. OCULUS, thanks for inviting me and Dr. Chan to come on. If anybody has questions for us, you see our emails up there. And thanks again, everybody, and have a great night.
Thank you, everyone.